name's Robyn, and I'm one of the anaesthetists at the Ralph. And tonight I'm going to be talking about the acute abdomen. So the way this is going to work tonight, hopefully, is I'm going to present you guys with a case. We're then going to go through what I call our case considerations. So how I basically would work through an animal that is presented to me. And then we're going to devise an anaesthetic plan together. Now, from the point of case considerations, devising the anaesthetic plan, it is going to hopefully get a bit interactive because I could just stand here and tell you everything, but I really want to hear what you guys have to think and get your input here. So what we'll then do is we'll use that. We'll then go into making our anaesthetic plan. And again, we're going to be very involved in here. I want to hear what you guys want to do. And then we'll have a little bit of a pause while I put all of that together. And then we are going to actually work through this case as if we are anaesthetizing them. So what we'll do is I do have a monitor that's hopefully going to come up on the screen, and we are going to anaesthetize this patient, as in we're going to have a monitor there, the heart rate, blood pressure, everything's going to do something, and then we're going to work through those problems together. And in a safe, controlled manner, because obviously there isn't actually a patient on the other end of the monitor, so we can try things, see what happens, and see if it makes it better, see if it makes it worse, and hopefully you get a nice understanding of actually seeing what your interventions are going to do. So our case tonight is a 2-year-old female neutered Labrador with a 3-day history of vomiting. She's acutely worse in the last 12 hours. Her carers report that she's quite quiet in herself, she's not eating, she's just really not right. You do your clinical exam, we find that she is tachycardic with a heart rate of 140. It is sinus though, lovely. She's got bounding pulses, and these pulses are synchronous with her heart rate. Great. She is quite painful on abdominal palpation, and post-palpation, she actually does regurg in the consult room. So you are suspecting that she does have a foreign body, and basically your plan today is you're going to do some imaging with probably some surgery. Now, I'm not going to go through imaging findings because that's not the point tonight. Tonight we're talking about anaesthetics. So basically we're going to assume she does have a foreign body and we are going to be going to surgery, but we're going to work through it as if we were going to do the imaging first. So when it comes to any anaesthetic, I tend to approach it based on 4 different systems. So my general anaesthetic considerations, my patient-specific considerations, condition-specific, and then procedure-specific. Now, the way I do this is because anaesthesia to me is a bit like a puzzle, where you have a patient, they'll have a condition, they'll have a procedure, and those things can always change around. And when you start thinking about things, you basically start making very long lists in your head of things that could happen in each of these cases. And then when you get presented with this case as having a procedure or a certain condition, it fits together like this beautiful big jigsaw puzzle to come out with this lovely big plan at the end. And hopefully as we work through it, you'll see how that's going to work. So the first thing we're going to talk about are the general anaesthetic considerations and the patient-specific considerations. The reason being, in this particular case, they're probably the least chunky section, and they don't really change a huge amount based on what's going on. So when we think about our general anaesthetic considerations, these are the concerns, these are things that can happen to any patient that is being anaesthetized because they are the effect of a general anaesthetic. And these are hypotension, hypoventilation, and hypothermia. Every patient, no matter who they are, no matter what condition they've got, no matter what procedure they are having, is at risk of these 3 things developing. And that is through the effect of our anaesthetic drugs. And it is our job to obviously try and mitigate those risks as much as we can. So then we think about our patient-specific considerations. So these are the things that are specific to that patient that is in front of you there, if everything else was taken away. So if you've got pets right now that are at home, that are young, fit and healthy, these are the kind of patients that we're thinking of. These are these considerations. So they're related specifically to the species, the breed, the age, temperament, quite a lot of the time, and sometimes our gender as well. The gender is more specific in sort of large breed animals, and more so in horses, but we can sometimes think about it in a little bit in small animals. So in this case, she is a dog who, as I like to think about it, is kind of our base species. They're kind of the one that are the most boring, if we're going to be perfectly honest about that one, that we would then build on for other species. She is, though, a Labrador, and Labradors are a large breed dog. So when we're thinking about that, we're thinking that our consideration is that they are more at risk of regurgitation compared to other breeds. So our small breeds aren't as high risk, whereas large breeds tend to be. Otherwise, her age, as I said, her temperament, she's a nice dog. These are all pretty standard. So there's not anything hugely specific we have to think about in that situation. So really, we're just thinking regurgitation in respect of her patient-specific considerations. Okay, so the next thing we go on to is we start thinking about the condition and what are our specific considerations relating to that condition. So we've already got a dog here who we know is quite sick. She sounds it. She's quiet, she's tachycardic, she's got bounding pulses. All these things should be flagging in our head. There's something going on with my patient right now. And for me, this is where then I start thinking about, right, what is this patient at high risk of, and potentially why are they at high risk of that? So for you guys, thinking about the condition that she has right now, so we think she's got a foreign body, she's vomiting, she's regurgitating, what would your considerations be based on that? So you can use the chat function or just stick your hands up and I will point at people, whatever you fancy. Yeah? Fluids, yep. So why are you thinking? So fluids are the answer. So what's the problem you're going to treat with fluids? Yeah, exactly. So we're thinking here this dog is losing fluid, so we're going to be at risk of hypotension. So that's first consideration here, and one of our biggest considerations is we're losing fluid, we're going to be at risk of hypotension, we need to have a solution for that. Great. Anything else? Yep, risk of aspiration. Yeah. So absolutely, this dog's at risk of aspiration because we are regurgitating. So regurgitation is, again, there's multiple reasons for this case regurgitating. So we've got a big breed dog who's already vomiting and already regurgitating, so they're really high risk. So we're therefore at risk of aspiration. Anything else? Shock. Yep, so shock, definitely. Again, that's what, I'm going to go for this, I'm going to be mean actually. So why are we thinking shock? What kind of shock are we thinking here? What kind of shock? So there's different classifications, and basically this one is going to be considered circulatory. So lack of volume, again, plus or minus any of the inflammatory things that are going on in this patient. So definitely. Anything else? Like sepsis, bacteremia? Yep, sepsis, bacteremia. And again, they're going to be related to, hopefully not in this case, because hopefully we're not quite there. But again, they are definitely things that are on our list. All right. Yeah. Pain, exactly, pain. She's already indicated she's painful, and pain is, in all honesty, everyone's worst nightmare. And while I think there used to be this train of thought, and I've heard it so many times, that pain's a good thing sometimes, actually in the cases of surgical surgery, pain we know is actually not very helpful in any way, shape or form. So pain is really one of these things that activates what we call our stress response. And during evolution, back in the good old days when you had to run from predators, this was a really useful thing to be able to do this stress response because it got you out of danger, it got you away from problems. But now what it tends to do is actually make things a lot worse. So it increases your risk of things like wound infections, complications associated with surgery, and actually we therefore don't want our animals to be painful, we want them to be comfortable, because obviously it's much nicer for the patient, but also because physiologically it's much better for them as well. Anything else? Yeah?
Would we not consider the foreign body itself, for example, if it's jagged, if it's sharp, it's going to be causing damage as it goes down, whereas if it's smooth,
Yeah, absolutely. So it's definitely consideration. It sounds awful. It's not necessarily something that I'm thinking about per se in that anaesthetic, because whether or not it's smooth, sharper thing, it's the same problem is potentially going to happen. We've got a patient who's got a foreign body that needs to come out. And yes, then it's the ongoing management, obviously into the recovery period, how they do post-operatively. But during my anaesthetic, I'm not going to be particularly concerned about what type of foreign body. I'm just worried there's a foreign body causing an obstruction. But definitely something you still need to consider, absolutely. Tissue necrosis, again, yep, we're thinking about these kind of things where these could all absolutely lead to complications, because tissue necrosis is going to lead to inflammation, vasodilation, hypotension, reduced tissue perfusion, absolutely. All right, so what we're going to do, hopefully this will come up with. Cool. So basically, I kind of divided these into 4 main things here because I could talk an awful lot about everything, but this is what I'm kind of thinking. So vomiting, we've already got vomiting. So one of the big things that's going to be associated with vomiting is you lose electrolytes and you lose fluid. So electrolyte imbalances and acid-base disturbances are really common in these cases. And what we tend to find is they are therefore then associated with things like hypotension, reduced tissue perfusion, and altered pharmacokinetics and pharmacodynamics. So that's a big set of considerations here that we need to think about, and then we're going to have to work out how we actually manage these. The biggest acid-base disturbance that you'll see in this kind of patient where they've got a foreign body and they are actively vomiting and regurgitating with it is going to be a hypochloremic metabolic alkalosis. I could talk about acid bases in a whole other lecture, but that's basically the most common one here. Regurgitation, again, we're going to have fluid loss, we're going to have electrolyte losses. Esophagitis is really common, actually, with regurgitation. So even if you're not actively seeing it, if they're regurgitating, there's a risk as well that they've got reflux, and esophagitis is horrible, to be perfectly honest, and puts them at increased risk of stricture formation, actually, in the post-operative period as well. So it's really important that we do remember that not just are we worried about aspiration, but we're actually worried about the damage to the esophagus as well, and what then we can do with that. If we've got the fluid losses, again, we're thinking hypertension, reduced tissue perfusion, altered pharmacokinetics and dynamics, and if we do have aspiration, then we're worrying about hypoxemia. It's going to be a big concern here. So pain, we've said we've got the stress response, catecholamine release, and splinting of the diaphragm. Now, splinting of the diaphragm with pain is actually quite common and really does contribute to the development of hypoventilation, which is obviously something that we have to worry about because we know that when we anaesthetise our patient, we're going to cause hypoventilation as it is. So now I've got 2 things together that are really going to make it more likely that our patient is going to hypoventilate. On the flip side though, pain can also cause us to hyperventilate. So you might find that some patients actually, when they're very painful, will puff and pant and actually hyperventilate. So they might end up having one, other, you could have a bit of both. So we'll see. It depends on the patient themselves. And then we've got to have stomach distension as well. So we do have to think about this. So you've got a very large stomach potentially here. This dog is regurgitated when you've pressed on the abdomen. It tends to suggest that something is quite full there. So we're thinking not only is that going to increase the risk of regurgitating, but also again, it's going to splinter diaphragm and it's then going to cause us hypoventilation as well. So we've got quite a lot of things already that we're thinking about from our patient's condition itself, but actually thinking about the procedure itself. So we're going to do some imaging and we are going to be doing some surgery in this patient. It's going to be happening. I'm going to tell you that now. So what kind of things do we have to think about and have to consider when it comes to the procedure? So even if this was a fit and healthy dog that was having an X-lap and some ultrasound, what would we be thinking about here? Positioning, yeah. So what's positioning? What's that going to do for us?
Increased rate of regurgitation, suppression of breathing.
Yep, exactly. So, yep, perfect. So they're the big things. So positioning here is going to be in dorsal recumbency for the surgery. We're going to probably be in lateral, potentially dorsal for the ultrasound as well. So multiple movements here, we're increasing our risk of regurgitation. Hypoventilation, absolutely, because we're going to be on our back. And again, the weight of the organs, the weight of everything onto the greater vessels, again, yeah, absolutely increasing the risk of hypotension. Anything else? Yep.
We're going to be having organs outside the body for investigation, so keeping them safe, keeping them supported, keeping them moist and clear.
Yes, and what's the big thing for us as anaesthetists that we actually would see per se? Organs outside the abdomen, so what are we going to see that's going to be our biggest thing that we're going to be worrying about? Yeah, temperature drop, absolutely. We're going to have an open abdomen, we're going to get hypothermic. It's huge, highly likely. Even though this is a bigger breed dog, hypothermia is still going to be hugely likely here. Anything else? Yep, warming aids, yep, fluids, perfect. So that's going to be the solution to our problem, yeah? Airway, so what about our airway? Yeah, so absolutely, we've increased risk of regurgitation, so yeah, we need to manage that airway properly. So we'll talk a bit more about that in a little bit, but absolutely something we definitely have to think about here. Anything else? Blood loss, yes, absolutely. So even if your surgeon tells you there is absolutely no chance there's going to be any blood loss here at all whatsoever, they're lying. Blood loss is definitely something we have to worry about here. And it's something that actually can be quite surprising. I have had people tell me that blood loss is going to be minimal, but at the end of the surgery, they actually ended up losing something like 20-30%. So just because someone says they're not going to lose blood doesn't mean they aren't going to lose blood. And in a patient where we've already lost a lot of fluid, actually then losing blood is going to be even more detrimental to this patient, and their actual ability to compensate for that is going to be significantly less. So hemorrhage is a big consideration here. Anything else? Yeah?
I know it's a pain, but just basically analgesia.
Yeah. Absolutely. So pain is a consideration for the surgery. So even if this patient wasn't painful before, the surgery is going to cause nociception and then pain in the post-operative period. So absolutely. So it is something that we definitely have to consider. And what you now see is you've got multiple, the same consideration appears in multiple places. So we start seeing that there are things that you'll see in a second that kind of start peeking out at you that we really then have to consider quite carefully in the planning of our anaesthetic. Anything else? Yeah?
I mean, I'll just give you a student nurse.
No, that's absolutely fine.
So with patients such as this, where we're already losing fluids, we don't want to lose any more blood because there is a possibility it's going to happen.
Yep.
Would this be a patient where you would consider blood transfusion? And if so, obviously, ideal environment.
Yeah.
All of us are in hospital or referral, but in this scenario, would this be something you would consider as an anaesthetist?
Yeah, so we can talk about, I'm going to go into that a little bit more later, but definitely. So when it comes to these kind of patients, you've already got fluid loss. So the thing that you're losing in these patients right now is not your red blood cells, not necessarily, hopefully not your proteins yet, but it could be a problem. So your red blood cells actually are still there. So what we're actually worried about losing when we hemorrhage isn't necessarily the red blood cell component, it's actually the everything else that goes with it. The actual volume is what we're concerned about from this. So yes, we start thinking about what is then the appropriate fluid to actually replace this with. So to start with, for me, a crystalloid is going to be fine to start with. But when we start seeing these patients where they are maybe responding, but then only for a short period, or we're finding that they're not responding, or we've had to give them quite a significant amount of crystalloid, then yes, I'm going to start thinking about, well, what is my next option? And then I'm thinking things like fresh frozen plasma are probably going to be my go-to. Reason being is it's a colloid, it's not natural, it's part of you, which is great. So it's going to stay within the vascular space for longer. It has things in it that are beneficial to that patient. So it's not just fluid, it has other things. It's got some of your clotting factors, it has lots of things in there that are very beneficial to your patient. People do think that it's got protein. It has a little bit of protein. If your patient is hypoproteinemic, so low protein, it's not going to fix that, but it's going to do something, is my kind of thinking. It's going to do something. It's going to do more than giving a crystalloid. So definitely in these cases, in the back of my mind, I'm thinking, well, I'm going to be having fluids. I'm going to be giving them crystalloids. I also need to remember that there is a chance that I'm going to be using a blood product. My first blood product is probably going to be plasma. My second is then probably going to be whole blood, because these patients haven't lost a lot of blood, and hopefully, unless your surgeon does something wonderful, won't be losing too much red blood cell. It's the fluid sort of component that we're worried more about. Gastric contents in the wrong places. Yeah, gastric contents in the wrong places, absolutely. Your surgeon's hands are going to be in there. They're going to squirt it out of the stomach. There's an increased risk that they're going to regurgitate, absolutely. Or empty it out into your abdominal cavity, because that can happen as well. Cool. So this is kind of the list I ended up putting in, and this is where I've got to go here to remember what I was saying. So pain and nociception is one of my top things I'm thinking about here, because we know it's going to be a painful procedure. So again, we need to make sure we're well analgesing, because we don't want a cascade race. We really don't want to add to hypoventilation. Positioning, we've got the dorsal recumbency. So we've got the hypoventilation, VQ mismatching. So VQ mismatching is where ventilation and perfusion are not aligned with each other. So what you then find is the ability of oxygen and carbon dioxide to move from your lungs and your blood is impaired, and you get quite big differences in carbon dioxide in your lungs and carbon dioxide in your blood, and oxygen in your lungs and oxygen in blood. So you end up with a patient who, if you took a blood sample, their oxygen will be lower than what you're expecting, and their carbon dioxide will be a lot higher than what they're expecting. Then if you add in the fact that this patient is probably going to be hypotensive as well and have reduced perfusion, again, that's really going to be contributing to that VQ mismatching. We've got multiple procedures here. Now, this is something that isn't necessarily talked about an awful lot, but when you have multiple procedures, even though it all sounds like one, you actually are increasing the risk of things like regurgitation, and you're also increasing your anaesthetic time. So they do come with an increased risk of hypothermia as well. And the longer an anaesthetic is, we do increase the risk of morbidity and mortality. So basically what we're doing is, the longer we take to do stuff, the more likely complications are to occur. Open abdomen, so the hypothermia, again, everything we've already sort of talked about here. So, but what you can see is we're starting to have things that are being mentioned multiple times that are going to be the things that we now need to plan for because they're really likely to happen. Okay, so I put these together so that we can see. This would be the kind of list that I would be creating in my head when this case comes in. So this is what I would be saying is, right, I've got a patient who is at increased risk of hypertension or reduced tissue perfusion because we're losing fluids and we're at increased risk of vasodilation because we know we've got a condition that could be quite inflammatory because we've got a foreign body, we've probably got inflammatory mediators going everywhere. So I'm starting to think, right, hypotension is really, really likely in this case. Regurgitation, we're already regurgitating. We're probably going to try and do that under anaesthetic as well. Acid-base disturbances, hyperventilation, altered PKDs, hypothermia, pain nociception, hemorrhage. So that's my list. That would be the things I'm thinking about in my head. Right, these are my problems. Okay, so what do we actually do? How do we plan for them? Because it's great knowing that these are things that are going to happen, but then what we need to do is we need to have a plan of action in place to try and mitigate these risks. So, hypotension. So this is our first one, and the reason I talk about this one first is because for me this is super likely in this case. This is going to happen. We are going to see hypotension. So I want to stabilize my patient before I anaesthetise them. So we know that if we try and stabilize our patient as best as we can before we anaesthetise them, the patient will do better. So I'm going to replace what I can. I'm probably going to be giving this patient a fluid bolus. We'll talk about that in a little bit. You guys can decide how much you want to give. We're at risk of vasodilation and reduced contractility. So I want to avoid and minimize drugs that are going to contribute to this. Sadly, basically every drug that I use in anaesthesia is going to cause that. So they are going to cause vasodilation. They're going to cause reduced contractility. So my aim is to try and give a multimodal approach. So I'm using smaller doses of multiple drugs to try and help reduce the chance of this happening, and also utilizing local anesthetics where I can, because they will reduce the other drugs that I have to give. And then I'm going to have a plan in place for managing hypotension. So for this case, because I know that my most likely causes of hypertension are going to be fluid loss and vasodilation with the reduced contractility, I'm going to be thinking fluid therapy, and I'm going to be thinking vasoconstrictors. So my fluid therapy in this case will start with a crystalloid. Now, because I know this patient is most likely going to be needing having a hypochloremic metabolic alkalosis, obviously I'm going to check bloods. I'm going to make sure that what acid-base disturbances we have, but making the assumption in this case, which is what this is what they've got, this patient will need a sodium chloride-based crystalloid with a potassium supplementation most likely, rather than your standard Hartmann's, because if we don't replace the chloride, we actually won't help correct the metabolic alkalosis that is there. Sadly, I can't bolus a bag that I have supplemented potassium. So I know I'm going to need to have a second bag of Hartmann's ready to go for bolusing if I need it during the procedure, because I know that I can't bolus anything that has a potassium supplementation in it. So that's something I'm already thinking about. So I've got my fluids I'm going to be having to stabilize my patient, to correct their fluid deficit, to correct their electrolyte imbalances, to correct their metabolic alkalosis, but I'm also going to have a second set ready for treating hypotension if it occurs. My next one is then going to be, as we said, is going to be blood plasma. Sorry, yeah?
Do you run them coincide together, or do you stop potassium and bolus and Hartmann's?
It depends on the patient. So I would be having my sort of replacement fluid there in the background at all times. I place 2 IVs, so I can run them concurrently, so I run them through separate IVs basically. If I'm worried that I am genuinely concerned that I'm going to be giving a blood product, then yes, I will run them both through the same IV. But what I will do is I'll drop my rate of my my replacement fluid is what I'm going to call it, so my sodium chloride based one, I'll drop the rate of that while I increase the rate of my Hartmann's. So it's kind of a balancing act between the two of them. Yeah. So I've got that in my head where I've got these things and I'm starting to think, I'm going to get all these things ready. I'm not going to be searching halfway through the anaesthetic for the bag of Hartmann's because I know I was going to need it, so I should have it with me in my tray, ready to go, basically. Vasoconstriction. So there are two drugs that I commonly use in these kind of cases. So this patient is sick. This patient is going to have activated their sympathetic nervous system and they're going to be using noradrenaline so much in their body right now. Sadly, noradrenaline is not an infinite resource in your body. We utilize it, we use it up, it then has to be reproduced, and it is not an instantaneous reproduction. So what we can find is actually, as they start using, and they are really using that sympathetic nervous system, they will start depleting their noradrenaline stores. And then what they have to do is either they have to produce more, or we have to give them more. So noradrenaline is usually one of my top go-to in these patients, because I know they're going to need it. Now, ideally, noradrenaline, we all hear and we all talk about it, should be given through a central vein and should be used only with invasive blood pressure monitoring. Yes, in an ideal world, that would be brilliant. Central vein, invasive blood pressure monitoring. But if your patient needs it and it's the option you've got, and without it that's going to cause more harm, then it is something that you should definitely consider using. So when we are using noradrenaline, the really important things to note are you must make sure your IV is patent before you start giving it. So what we don't want to do is have it going subcut, because if it goes subcut, what's going to happen is you're going to get vasoconstriction in that tissue and potentially lead to tissue necrosis. So always, always make sure the IV is patent, you're happy that it's flushing, you're happy that nothing's going subcut. And make sure that it is going through its own port, not with anything else, because what you can accidentally do, which we have all done in our lives, so we will have to admit it, is you accidentally bolus noradrenaline. Now, most of the time, because it's a small amount, it's absolutely fine, it's not too big a deal, but what you can find is you end up with very profound vasoconstriction and sometimes a bradycardia with it, and no one wants that in their lives. We don't want to bolus it. So make sure if you can that it's always going through something on its own and it's not piggybacking off of anything else. Okay. The other drug you can use, which may not work necessarily in these cases, but it's something that if you don't have noradrenaline or you're worried about using noradrenaline, is using what we call ephedrine. So ephedrine is something we can use to cause vasoconstriction, and basically it makes your body release a little bit of noradrenaline from your nerve terminals and stops the breakdown of it quite as much. So the idea is you'll hopefully get a little bit of a boost from the noradrenaline that is there. Now, the reason that I would use this cautiously in this patient is because we know we're probably already using up all of our noradrenaline. However, while you're potentially getting the noradrenaline set up, or if you are really worried about using it, it's something you can definitely try to use. The biggest thing is it's short acting, so you'll probably get an effect for about 10-15 minutes, and you can't repeat it too often. So you probably find you can give it 2, maybe 3 times maximum. In this patient, I would be probably saying once or twice is probably enough, and if not, you're really having to think about using that noradrenaline at that point. Okay, so they would be my kind of go-tos for vasoconstriction for this patient. Okay, fab. So the next biggest concern for my patient here is regurgitation. So regurgitation is absolutely going to try and happen at this point in time because you've already done it just by pressing on the stomach in the consult room. Great. So what are we going to think about to try and reduce the risk? Well, can you place an NG tube in the patient before you anaesthetise them to try and suction out some of the stomach contents? If you can, amazing, definitely do that. It is a great idea. If you can't, don't worry. Don't stress about it. It's a good thing to be able to do, but if you can't, there are other things we can do, and that's just by managing our induction and knowing what to look for and knowing what to do in an emergency situation. So I would, for patients regurgitating, always pre-treat them with omeprazole and meropitant. Now, meropitant, I'm going to say, is an antiemetic. It is not going to stop your patient regurgitating. But what it will do is stop your patient vomiting or reduce the nausea associated with vomiting. And while it's not going to help necessarily the regurgitation side of things, we know that they've got a full stomach. We know that they are therefore already got fluid there that's trying to come out. So let's not have them vomit at the same time, because we really don't want that happening. Omeprazole, again, isn't going to stop you regurgitating, but what it is going to do is increase the pH. Neutralize your pH of your stomach contents. So we're reducing the risk of esophagitis, which is a really horrible thing to have. My own dog actually ended up with really nasty esophagitis, and I can say I didn't realize how horrible it was until I had to live with a dog that had it for about 6 months, because it took a really long time to get better. So I can say whatever you can do to help with it, definitely please do. Now, in this case, obviously, we know that there's, in other breeds, we potentially think about metoclopramide. Absolutely not using it in this case at this point in time. We have a foreign body. Metoclopramide is prokinetic. It's going to try and move your guts. We don't want that happening just now. We want to leave those guts as they are. We can leave that for post-operative, but right now, I'm not going to be thinking about that at this point. Cool. And then we're going to have a plan for when this patient inevitably regurgitates as we're anaesthetizing them. So when is the most likely time your patient is going to regurgitate? After pre-med, yep. 2 more times. Yep, so absolutely, when you are repositioning, when you're moving, when you're playing with the abdomen, do I worry about it as much at that point in time? Yeah, exactly. So the points in time that there are so many points that we could regurgitate, but the biggest points that I really, really worry about are after pre-medication, as we're inducing, because that is probably the highest risk period at that point in time, because your dog is losing consciousness at that point in time, so really cannot protect their airway. And then on recovery is your other big risk period. In the middle, absolutely, there's still a risk. Every time the surgeon presses the stomach, every time you reposition your patient, we are risking regurgitation. But because we've got an endotracheal tube in, because you've cuffed that endotracheal tube, we're worrying less about the consequences of it. We still have to manage it, but we're worrying less about the consequences. Cool. So I'm thinking for this one, I want to have a head-up induction. I want to have suction at the ready, have it ready, definitely. So that if they do regurgitate, you can manage it immediately. And when we get to the recovery phase, we're going to be doing a late extubation. So keep that endotracheal tube in for as long as possible. Extubate them when they are head up, looking at you, swallowing, absolutely. As long as they will tolerate that tube, leave it there. Okay, so let's go. Acid-base disturbances, we've already chatted about this briefly, but basically I'm going to make sure that I actually check a blood beforehand. If you can't, if the caterers are not keen, my minimum that I would like to be able to do would be something like a blood gas, PCV total solids. I think that's going to give you quite a good amount of information. If you can get more, obviously absolutely do, but that would be kind of the bare minimum of what I'd be looking for. Select your fluids based on what you see, because actually you can have quite a significant effect on your acid-base balance by the fluids you choose, and reassess them regularly. So just because you assume that it's going to be okay, doesn't mean it will be okay. So start something, reassess it if you see any complications, or on a regular basis as you go through the recovery period. Okay, hyperventilation. So again, we've already had a few things that are potentially going to contribute to the development of hyperventilation. So really what we're going to try and do is avoid and reduce drugs that are going to contribute to that. Again, sadly, most of our anaesthetic drugs are going to cause this. So again, it's about using a multimodal approach to try and avoid having high doses of one particular drug that is really going to contribute to this. Treat the factors that are contributing to it. So remove as much fluid as you can. Only position in dorsal really when you need to. Try and avoid leaving them in that position for prolonged periods if you don't have to. And definitely treat pain, because pain is going to really contribute to this as well. And the solution is going to be mechanical ventilation. If you have tried everything, you've tried maximizing your anesthetic-sparing drugs, you've optimized your anesthetic as much as you can, you've got rid of as many confounding factors as possible, mechanical ventilation is going to be your solution to this one. Cool. Altered pharmacokinetics. So this can happen. It's really hard to assess. We don't actually know if it's happening, but you can kind of presume it is going to. So we really want to use short-acting reversible drugs where possible, titrate to effect, and absolutely using a multimodal approach again. and using local techniques where possible. The reason being is we want this patient to recover. We don't want them to have a prolonged recovery. We don't want them to be at increased risk of side effects from the drugs that we're giving. So if you try and use lower doses where you can, and by combining it with the local, you can really have quite a wonderful effect there. Hypothermia, again, you will all know this, but temperature drops as soon as you start giving any medication, so start treating them then. Don't wait till they're hypothermic to try and stop them becoming hypothermic. It's far more effective to start warming at the start. Obviously, you've got all your normal things that we're going to do for preventing hypothermia, so your forced warm air blankets, hot dogs, heat mats, bubble wrap, foil blankets, all these kind of things are great. But obviously, please don't forget to ask to use warm fluids to flush the abdomen out with during surgery, because if you add cold fluid in, that is going to really, really negatively impact your patient's temperature and will make your life an absolute nightmare. And finally, you do want to make sure you're monitoring closely, because what we don't want to happen is your patient become hyperthermic, because that's going to have a whole set of problems associated with it as well. So that's going to increase your metabolism, it's going to increase the risk of coagulopathies and everything that could happen. So just obviously we don't want them cold, but don't cook them either. Yep, pain and nociception, analgesia is going to be our biggest friend here. Make sure we're using analgesia, preemptive where possible. Obviously this dog is already sore, but what we don't want to do is we want to give them analgesia before they get more painful. And again, the multimodal approach here is going to be really important. Hemorrhage. Okay, so although it is lower risk, it is still a possibility, and because we have a dog that is already volume behind, hemorrhage could have quite a profound effect on this patient. So calculate your blood volume prior to surgery. So for dogs, it's 90 mils per kilo. For cats, it's about 55 to 60 mils per kilo. And I personally always calculate it in high risk procedures, and then I will also calculate what my 10, 20, and 30% losses are, because if I know that, I can then kind of, by looking at things, I can be like, yep, that's looking roughly like we're getting to that region. I probably need to start worrying now. Obviously, you're going to base it clinically as well, but not all patients have quite the same change clinically for blood loss as some other patients. So some will, you have a little bit of blood loss, they're quite reactive to that. Others, they lose 30% and you wouldn't even believe it. So it is still important to keep an eye on it and know roughly how much we're losing. Monitor those losses. So in this kind of procedure, I wouldn't be doing a blood count full blood count, every 5-10 minutes. I'd be just keeping an eye on what's in my suction pot, what's in my drapes, how much fluid have they put in, because it takes time. It's faffy to do a full blood count, and it's just going to prolong things. I just need to roughly know, is that looking a lot or is that not looking very much? Because plus what my patient is doing. At the end, I will do a full count to see what the actual loss has been, but I'm not going to be too worried in the moment about the exact number. I'm just going to be worried about, does that look a little, does that look a lot, how is my patient doing? And really communicate clearly with your surgeons. So what I tend to find is sometimes what you see clinically doesn't match with what the surgeon is seeing. And what they can think is this has only been a small loss, but your patient is acting like it is a huge loss. So have that conversation with them. Don't be afraid. I appreciate that sometimes surgeons can be stressed. That conversation can be challenging. But as long as you present fact, as long as you are professional, never feel bad about having that conversation, even if that conversation feels difficult. You are your patient's advocate when you're anesthetizing them. You are their voice. You are their best friend at that point in time. You are the one who is responsible for making sure they come out the other end okay. So these conversations can be difficult, but please make sure you're having them. There is no point in you sitting there thinking, oh my goodness, this is hemorrhaging loads, but the surgeon's ignoring it. Try and voice it as best as you can. And as I always think, is if you present fact and you present it in a professional manner, they can react their way that they want to, but you know in yourself you've done the right thing. Okay. Cool. So that's all our considerations. So basically our aims are, don't make things worse, pre-treat where we can, and plan for the complications. So what I now want to do is ask you what you want to do. So I've given you a lot of information here, but I know what I would do because I know what I have in my practice. I know what I have available to me, but that's maybe not what you can do. So I know I have a lot of drugs. I can imagine that not all of you have every drug under the sun. And therefore, me telling you that this would be my ideal plan is useless to you guys. So what would you like to do? So the first thing I'm thinking is pre-anaesthetic management. So what would you do in this situation? What would you want to do with this? Again, just either raise or pop them on. I don't mind either way. I do have things that we will add. Yeah?
When they've got somebody and they're like brick red in the mouth,
Yep.
you said that blocks with it. How much fluid is the correct amount of fluid?
That's a good question.
Which I know is like how much piece of string.
Yeah, that's the answer. So when they're that brick red, so you've got,
Should you bolus them
yes.
before surgery massively and keep going during and after? Like when is the
Yes.
too much? Yeah.
Absolutely. So patients who have a foreign body, and this kind of patient that I'm kind of presenting is kind of like one with a sort of high up obstruction where you do have a stomach that's filling with fluid and emptying out quite regularly. So if your patient is tachycardic, you've got bounding pulses, you're talking about brick red membranes, we know there's fluid losses, they need fluid. So the rule of thumb, if you go to some of the guidelines, is like 90 mils per kilo is what you should be replacing. Give, I think it's a quarter of it, then reassess. It gets quite complicated. What I tend to do is I look at my patient and go, you need fluids. You're a big breed dog, you look like you need quite a lot. I'm going to give you a 10 mil per kilo fluid bolus here. And in this patient, I'm going to use Hartmann's for my bolusing fluid because that is appropriate to do so here. And I'm going to give you a 10 mil per kilo fluid bolus, and then I'm going to reassess how you look. Has my heart rate improved? Has my blood pressure improved? Which is obviously what we would like to do in this patient. And then what I'm going to do is go, okay, do I think that my patient is now cardiovascularly stable, but still needing replacement? And if that's then, at that point, I'm then going to have them on potentially somewhere between 4 to 6 mils per kilo per hour, depending on how crispy I think they are, which I'm going to potentially base on my PSV total solids, clinical exam findings. Or am I still tachycardic? I've improved a little bit, but I'm still quite tachycardic. I'm going to repeat that bolus again. So I tend to give up to around about 30 mils per kilo. If I'm getting to that range, I'm thinking, okay, am I having to change tack here possibly? Is it potential that I might need to start thinking about something? But these patients can take an awful lot of fluid, especially if we're thinking about the patients that are potentially bordering on septic. So if we're worried this patient actually has a bacteremia, has a septic process, they can take a lot of fluid to correct them. And there isn't a right answer to say that this is how much fluid you're going to have to give. It's going to be you're going to give, you're going to reassess, you're going to give, you're going to reassess. And if your patient is improving, that's what we like to see. If your patient isn't improving, we're then thinking, right, I've got to 30 mils, I've got to 40 mils per kilo. I'm potentially going to be thinking, am I changing tack to my fluid? But I'm also going to be adding in things like noradrenaline at that point in time, because I know that it's not just volume that's the problem. If I'm worried I've got a lot of inflammation and a potential septic process going on, I'm going to be adding in my vasoconstrictors. I'm going to be adding in something to help support vessel tone while I help fill the volume, because volume isn't the only component of blood pressure. It's a combination of volume, heart rate, vascular resistance, and then when we think about it as well, also contractility. So we need to not just think about the fluid, but also everything else that comes with it. Does that make sense? Yeah. I wish I could say you'll give this amount of fluid exactly and it'll be fine. It doesn't work that way, sadly.
Post-surgery, you'd expect them to be less tacky and or at that point you should have reassessed it.
Yeah, so what I'm thinking is I'm looking for an improvement in blood pressure and I'm looking for an improvement in heart rate. I'm not necessarily looking for an improvement in how tacky their mucous membranes and things are, because that's suggesting more of that we are potentially got a dehydration component going on here as well. That's going to take time to replace. I'm worried more right now about the cardiovascular system. Am I getting that to an okay state? So improvement in heart rate and improvement in blood pressure and pulse quality is what I'm going to be looking for mostly in that situation. Okay. Yep, pre-warm, give a omeprazole and imiperin. Yep, perfect. That's exactly what I'd be doing. Anything else?
Pain management.
Yep, pain management. Blood typing, yeah. In this case, I will admit, you can blood type, absolutely, if you've got it. If you don't have it, don't worry about it, because at the end of the day, if they're transfusion naive, you are going to end up giving them whatever you have in your supply and not worry too much about it. Fab. So, analgesia, gastroprotectants, blood gas analysis, and if you can, use a decompression. So these are the things that I would be doing for this patient before I try and anaesthetize them. Okay. Okay, so now I've got to think about pre-medication. What do you guys want to do? There are, and I will say this here, the things that we want to think about are, hold on. Oh, sorry, yeah, attached monitoring patient allow. Right, so these are the only two things that I'm going to say that you definitely should be doing. Otherwise, everything else is going to be left up very much to you guys. All right. Opioid, absolutely. What opioid do you want to go with? Methadone, perfectly. So full mu opioid agonist, great, absolutely in this case. Who here actually has methadone in their practice? I'm hoping everybody. Okay, most people. Okay, this is good. Okay, maybe it's better. Who doesn't have methadone? Okay. So if you don't have methadone, fine. Do you have any full mu opioids other full mu opioids? Oh, buprenorphine. Okay. If you have only got buprenorphine, use buprenorphine. Okay, that's what you're going to use because that's what you've got. Ideally, yes, we would love to use methadone in this case because this is going to be uncomfortable. They will need it. But we have other drugs that we can use that will really help with this. So whatever you have is going to be the right option because there are so many other things that we can do. So an opioid of some description. What else are we going to go for? Medetomidine. Cool. So this is the probably one and only case I would not use an alpha-2 in. So I am the biggest fan of alpha-2 agonists in the whole world. I love alpha-2 agonists. But in this patient, I wouldn't. The reason being, their vessels probably aren't going to vasoconstrict very well with medetomidine, so you're going to cause them to be bradycardic and massively vasodilated, which is just going to contribute to hypotension. So I wouldn't give them an alpha-2 in this one. However, the caveat to that would be if this dog was very fearful and trying to potentially bite, lunging, that kind of thing, then I would be, because that would then got to balance the safety of the patient, the safety of the staff, and their outcome. The good thing about an alpha-2 agonist is it is antagonizable, which is great, so you can give it and then antagonize it once you've got the patient to the safe place. But appreciate that it does have very profound cardiovascular effects and can be quite detrimental. So I wouldn't standardly use it in this patient when they are, basically if I'm thinking sick patient, I probably wouldn't use unless there's a good reason to use it, which would be basically that they are trying to they're really not enjoying the situation, having a go at someone. Okay. So yeah, so basically my pre-medication would be an opioid in this case. Whatever opioid that would be, it doesn't necessarily, well, I would lean towards obviously methadone. But if you've got buprenorphine, that's what you're going to use. You can add midazolam into this as well. So midazolam is an option here. The caveat to this is midazolam can occasionally cause a little bit of excitement in some patients. If they're sick enough, it usually doesn't, but just be aware that if you do give it, you might see a little bit of excitement at that point in time. Fab. So that's what I would do for my pre-med, and I wouldn't be giving much else at that point in time. Yeah?
I feel like every time I use midazolam, that happens.
Yeah.
I always wonder, like, if that does happen,
Yeah.
is that detrimental?
No.
Or not?
No. It's one of these things that we see, it's not detrimental to the patient. You might find that then you do have to give a bit more of an induction agent to induce them, which is why I will sometimes use it as what I call a co-induction. So give a little bit of an induction agent first of all, and then chase it up with the midazolam, which you usually find mitigates that risk from happening. However, if they are sick enough, midazolam and an opioid pretty much does induce them, which is great.
We have had this a couple of times with our patients as well, and particularly we found a little, I don't know if it's a life hack, but something that we've actually found, utilised, and it has worked every single time, is using the thickest blanket you have in practice.
Yeah?
Make sure it's out of the tumble dryer.
Oh, cozy, yeah.
And tuck it in.
Yeah.
Literally, it doesn't matter how big or small.
Yeah.
Tuck it in for the patient, as they have their excitement, we'll tuck it in further.
Nice. So that works basically. So basically where it's working is it's and this is where I've got to get it right. Basically, you're kind of flipping the switch in your brain. So you're basically turning on the switch of, oh, I'm really excited, I'm having fun, yay! So that kind of thing where you do just calm and talk actually does work quite well. Some of them, they get really excited and they will run across the room, regardless of what you do to them. It's fun. But usually when they are this sick, we're talking really sick patients, you tend not to find that happens. You tend to find that they do just go to sleep with it, which is really, really nice. Okay.
Would you use only on opioids?
So, yes, I would. So if the patient is sick enough, my tend to go to would be either methadone for pre-medication, or I don't give the methadone, I just go straight to fentanyl, midazolam, plus minus with a bit of propofol is usually my go-to, because I tend to find that works. They don't need much else. When you're cardiovascularly compromised, actually you tend to find that what you need to actually anaesthetize your patient is massively reduced. So yeah, I don't tend to add anything else. The other drugs that we have out there, if we're really thinking about it, we've got alpha-2s, ACP, are our main sedatives, and neither of them are really appropriate in that case. So we're thinking opioid, benzodiazepine, can be diazepam as well, and they would be my kind of only ones I would potentially be using in this. We do also have ketamine, which is great. In these cases, which we absolutely can use. So the brilliant thing about ketamine is it's analgesic. It also has an anaesthetic sparing effect. It itself is an anaesthetic, so actually has a lot of benefits in these patients. I don't tend to use it as pre-medication in cases because you have to use it with something else, either midazolam or an alpha-2. So in this case, we would use it with midazolam because of the risk of muscle rigidity with it. So what I would tend to be doing is I tend to either do that as a co-induction, so again, giving it with my induction agent, or using it with midazolam at lower doses than I probably would do if I was using an alpha-2 agonist, because actually it can be very effective. It's good analgesia, and it is going to be help reduce the amount of induction agent you use to induce as well. And very importantly, you can use it as a CRI during the procedure for their max sparing effect and for its analgesia as well. Yeah, so absolutely you can. Again, it depends on the patient. This patient, they're probably not going to absorb it very well because you're not going to be perfusing your muscles very well. So I tend not to be sticking more with IV in this. But for fit, healthy patients where you want it for its analgesia, maybe a little bit of time to avoid the respiratory effects of it, I do give it IM quite regularly. Okay, so induction. What do you guys want to use for induction? How would you guys induce? What do you have? Here we go. Propofol, great. I love propofol. Propofol's amazing. Not that alfaxone is bad. That is a really horrible way to say it. I like alfaxone as well, but propofol is my go-to, definitely. So both induction to effect, but try to be quick because this is a point at which your patient is going to regurgitate and potentially aspirate. So you need to be to effect, so you're not giving too much, but quick enough that you're not increasing the risk of them regurgitating and aspirating. Have your suction ready, keep the head up until the airway is secure, and yeah, propofol. So if this was me, I maybe would give methadone, maybe not. I'd probably do fentanyl, midazolam, propofol co-induction, because that's what I like to do, and I find that that works particularly well. But we don't necessarily have that, so I'd be saying methadone, and then I would do a co-induction with midazolam and propofol in this case. Cool. So my question here, what do you do if the patient starts regurgitating before the trachea is secure? So you start giving the propofol, and before you can intubate, the patient starts pouring at you. What do you do? Yeah? I'm presuming that was everything. Hang them over the table. Fab. Great. Thank you. So there is this really big need that people want to still try and intubate. Please don't. I have seen that go very badly wrong, depending on what's in their stomach. Hang them, suction. Hang them and get the suction in there as quickly as you can. Get someone, make sure they're monitoring the pulses, make sure they're monitoring their patient is still okay. And as soon as you can, then intubate them. But yeah, keeping their head up to try and intubate while fluid is coming out at you is very difficult. You can't see what you're looking at, and massively increases the risk of aspiration. And if you then start having chunks coming out, you will find that it can be detrimental to the patient and actually can end up in the patient's death. So tip, suction, intubate. Fab. Okay, so how do you want to maintain this patient? On a gas, fabulous. What gas? Who's got what? ISO, great. It doesn't matter which one you use. Both of them are going to be fine. Use one you're familiar with. Don't start playing around with something that you've never tried before. Cool. Anything else? Ketamine CRI, yep. Ketamine CRI, alpha-2 CRI, not alpha-2, sorry, wrong. Opioid CRI, if you've got fentanyl, absolutely, definitely be using something like that.
Can you use locals to try and reduce this?
Yeah, absolutely. So in this kind of case, I would be doing either a TAP block if you can, so transverse abdominis plane block, line block, if you, or would be my two go-tos in this. Some people would potentially mention epidurals. In this case, I wouldn't, because if I put a local anaesthetic epidurally in this case, I'm going to drop this patient's blood pressure. I think the benefit doesn't outweigh the risk at this point in time, and also it's an extra movement, so you're going to have to go do, 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 to get an epidural done and then clip for them. So I would just do local on the abdominal wall, so either tap block or line block. Oops. I'd also potentially add in as well paracetamol. Yeah.
And when you take the line block, are you wanting it to last a little bit longer? Are you using something like,
Yeah, I tend to. So because, it sounds really bad, the process for me to get from prep to theatre first incision is slightly longer, so I have a little bit longer for my drug to work. But if you've got lidocaine, use lidocaine. It doesn't matter. Either or is absolutely fine.
Do you give antibiotics per option?
Yes, so in this case, yeah, I probably would. I will be honest, my surgeon's preference is I don't get much of an opinion in that one. It's what my surgeon wants, so I go with what they want. But yes, in this I would be, we're opening the GI tract and your patient's already quite unwell. I would be using antibiotics. Something like a comoxiclav would be what I'd be thinking, or preferably cefuroxime, because comoxiclav they're probably going to react to. But that's just me having PTSD from the comoxiclavs. Okay. And post-operatively, again, we're thinking analgesia, fluid therapy, extubate late, and keep them warm. Okay. So the plan for this patient, so that we can summarize here, we're going to give them methadone, we're going to induce with propofol and midazolam, we're going to maintain on an inhalant with probably a ketamine CRI, because that's what I know most people have. We're going to do some form of local block. We're going to give them some paracetamol and some antibiotics, fluid therapy, keep them warm, and that's what we're going to do. All right. So we're going to take a very short pause while I make my next screen work. So please go and eat some cake, have some drinks, have a pee, and then come back in about 5-10 minutes, and I will hopefully have the next bit ready. So basically the idea is we're going to have things happen. The monitor will change. You guys are going to tell me what we're going to do. All right? Please just shove your hand up, shout at me. The glorious chat function has now decided that it is not doing what I want it to do. So I'm just going to focus on this. Okay. So the plan that we went through is what we've done. You've anesthetized your patient. This is immediately following induction. You've got your monitor on, and this is what your patient is looking like. Are you guys happy? No. No, great. Why are we not happy? Don't let the blood pre, great. Tachycardic, great. Cooking it slightly. I am cooking this patient slightly, great. And anything else? Yeah, bet low. Okay, so what is going on here? Hypotension, great. So we are hypotensive, and hypotension is going to explain everything on this screen right now. So hypotension is going to be causing us to be tachycardic, and it is going to be causing our hypocapnia as well. Yes, the temperature is high, but this patient is unwell. We're thinking there's an infectious process, potentially sepsis here. So that's explained by that. So what are we going to do? So why is this patient most likely hypotensive right now? Fluid loss, yep. What have we also just done? Anaesthetize them. Okay, so fluid loss, and we have got vasodilation probably going on here, maybe a bit of reduced contractility as well. Okay, what do you guys want to do? Check your ISO. Okay. My ISO is on 1% right now. Okay. Cool. What was that, sorry? Okay. Anything else? Could you bolus? Great. So what do you want to go for? Who wants to go for a bolus? Okay, great. Fab. So I'm going to give a 10 ml per kilo fluid bolus to this patient. Okay. Hopefully this will start working. Oh, no, I don't want an arrhythmia. Thank you. Okay. Fabulous. So our patient is looking a little bit better after that fluid bolus now. Great. Okay. So we're going to now, thinking that that was a 10 ml per kilo fluid bolus, what are we expecting to happen in the next little bit of time? Going to drop again, yeah. All right, so that is our first fluid bolus that has happened, and what we have treated there is we have treated volume. Now, in this case, actually treating vasodilation, so bioethanoadrenaline CRI, would have also been appropriate in this situation, because what you have done is you have vasodilated your patient from the induction agent and from the inhalant that you have now given. So when we think about blood pressure, there are, as I said, there are the three main components. So they are heart rate, stroke volume, and systemic vascular resistance. And stroke volume is basically made up of preload, afterload, and contractility. So volume, how well your heart's contracting, what your vessels are doing, and how fast your heart's contracting. In this situation, when you have vasodilation, you have two ways you can treat it. Now, normally when we say vasodilation, I would always reach for something that's going to vasoconstrict, because that is actually treating the problem. But this patient has volume loss already, and even though I've not lost volume on induction, what I have done is made that space bigger. So the little volume I have now has to fill up even more of a space, so your blood pressure drops. So giving volume in this instance would absolutely be appropriate, but if we'd gone for vasoconstriction, that would have been fine as well. Okay, so we're clipped, we're prepping, we're about to go to theatre. We've moved in and everything seems fine. We've done our checklist, because we are, very importantly, we've done our checklist. Surgeon's about to start and say, can we do our first incision? Are you guys happy to do it at this point?
I would want to be checking my anaesthetic monitoring, just in case that EPCO2 is equipment related.
Yep.
I would also be looking at temperature drop that's just now.
Yep.
So I'd be readdressing my temperature, looking at how warm my fluids are, whether I
Yep.
need to be doing a fluid warmer. Once I have done that and I've seen improvements, then yes, I'd be happy.
Perfect. Exactly. So I think, yeah, double checking that you're happy with everything. So a massive temperature drop like that, I would just double check that my temperature probe is still in the patient, because I've just moved them. But otherwise, yeah, I'd be saying, yep, absolutely, let's crack on. So you crack on, your surgeon starts making their first incision, and this happens. Okay, and let me do this, sorry, I've got to do one at a time. Okay, so what's happened? Yeah, okay. So the most likely thing going on here, as you're all saying, we need analgesia. We have nociception going on. Great, fantastic. Nociception, the treatment for nociception is analgesia. But what is nociception going to do? So remembering our isoflurane is only on 1% right now. Okay. Yeah, so we really need to be worried right now about emergence in this patient. So emergence and pain are our two things here that we're really, really worried about. So check your depth. Make sure that they are still asleep, or by doing that, and get your surgeon to stop what they're doing for a second. And then we're going to give analgesia, absolutely. So this patient is still appropriate depth. We're happy with our depth of analgesia, depth of anesthesia. So we have gone, we did a methadone, we've done our midazolam and our propofol induction. We have them on a ketamine CRI, and we did our tap block. So what do you want to do? Could give some fentanyl, absolutely. Anything else? Give ketamine. Okay. So you have two options here, absolutely. I could go get something else, so I could go get fentanyl, and I could give them a fentanyl bolus, or I can use what I've got there. What I've got there is ketamine, and it is effective, it is analgesic, and it is going to be quick to act, and I don't need to go get it at that point in time. So I would say I'd probably give them a ketamine bolus, and then get the fentanyl ready for when the next time, if this happens again. Okay. So we give the ketamine bolus. Okay. And everything sort of improves a little bit. And then we end up with something that looks a little bit like this. Oops, nope, that is slightly more appropriate. There we go. Hopefully it doesn't show you exactly what I just did for our patient there. Yes, it did, yeah. Okay. So we've given her a lovely ketamine bolus. So I've given a 0.5 mg per kg ketamine bolus. What's happened? Breath holding, yeah. So we're hypoventilating. So ketamine doesn't necessarily, and I can't change the exact pattern here, sadly. So ketamine doesn't necessarily cause you to hypoventilate, but it will change your respiratory pattern. So it will slow it down. You may end up with a pattern that's a little bit fast, 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 slow, fast, 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 slow. It's normal. Don't worry. We're fine. We're happy with that. Everything else is improving. My carbon dioxide, yes, has gone up a bit, still within normal limits here. I'm fine with that. I'm okay with that. And if my patient stays like this, I will be really, really happy. Are you happy for your surgeon to start operating again? Yeah, great. So we've got our fentanyl now in our hand, ready, in our tray if we need it. And yeah, this is where we're now sitting at. Okay. So what's the next part of surgery, obviously, is they're going to make their incision, and then we are going to obviously go into the abdomen, and they're going to start moving, potentially like removing organs, taking organs out of the abdomen to get access to where we need to. So this dog we have found has got a pyloric obstruction, and we're suspecting, because I love this one, that she's probably eaten a corn cob and it's wedged right in there. So we're going to make an incision in the stomach, and we're going to hopefully remove that lovely bit of corn cob that's in there. So surgeon starts doing surgery, and gradually this just seems to start happening. Okay. Okay. Okay, so what's happened here? Yep, blood pressure slightly dropped. Temperature's dropped. Yeah, we've got an open abdomen now. ECO2 has dropped, yeah. So when we start having surgeons' hands in an abdomen, as wonderful as that is, because they're going to fix the problem, they create problems themselves. Lovely people there. So the biggest problem that we've got here is surgeon in abdomen is going to put pressure on our greater vessels. Now, in a normal patient who is not behind in their volume, they will cope really, really well with this. They wouldn't care. So things like your space and everything, you don't notice it massively when you put your hands in the abdomen because they cope well with it. This patient is vasodilated, and this patient is behind in their fluid. So when the surgeon puts their hands in and starts compressing things, even if they are super, super gentle, these are the kind of things that we see happening. Now, at this point, I'm looking at this patient going, okay, things have dropped a bit. I'm not panicking here. I'm not super worried. I'm not asking them to stop anything that they are doing because that's just going to prolong my anaesthetic, and I can manage the situation going on here. So what could we do? Another bolus, yep. Anything else? Readdress our ISO, yep. Anything else? Vasoconstrictors, yes. Again, it's the same three options that we were thinking of earlier on. So absolutely, I'm going to check my depth of anaesthesia because I have given ketamine. I know my ketamine is going to be having an effect here, so it's going to be max sparing. So I'm going to see, can I reduce that isoflurane anymore? The point at which we're at will depend on if you have gas monitoring or not. So if you don't have gas monitoring, so where you can actually see what your end-tidal isoflurane is, I'm probably a little bit more cautious because what you don't want to happen is a patient that's becoming aware. When you have gas monitoring, you can get quite low because you can see exactly what your patient's getting, which is nice. So if you are going to drop your ISO further, make sure you are continually reassessing that depth. Don't forget about it, because what you don't want to happen is the patient start to wake up with surgeon in abdomen. Okay, and then yes, absolutely, we can either go for more volume or a vasoconstrictor. So in this situation, either of them would be absolutely fine because we've only given one fluid bolus during this anaesthetic as we are, so we've still got room for volume expansion, and a vasoconstrictor would also be appropriate. Now, because I know I have one of them ready and I know I don't have the other one ready, what am I going to probably do? Volume. So I'm going to give another fluid bolus at this point in time while I ask someone to go and get noradrenaline ready because I know I'm probably going to need it. Okay, so we're going to go like this. So we're giving another 10 ml per kilo fluid bolus. I'm a bit far there. Okay, so we can see the patient's improved, but not as much as the last time. okay? So we've given volume, but it's not had the same effect of what we want to happen, okay? Everything else is sort of, we're now teetering, everything seems to be just sort of sitting around about the, we're okay, but we could do better. So depending on how far into the surgery we are at this point in time, and depending on how the surgeon is doing, will then sort of depend on what I do next. So I could just say and go, oh, if this was towards the end of surgery, like, we're fine, we're about to start waking up, I'm not going to worry too much right now. But this patient, we've only just got in, we're really just getting into the abdomen, we're just getting that stomach opened. So I'm going to be thinking, do you know what, let's start getting that noradrenaline CRI on right now, because my fluid's not done as much as I want it to. So is it that I've kind of maxed out on my volume and now I need to think about my vessel tone more? And I'm going to say, yeah, that's probably what I'm going to do. So I'd be thinking about that. So my noradrenaline CRI, I would start at the lowest. So mine would be 0.1 micrograms per kilo per minute. Always get the units wrong for that one. And I'd start at that. And I would give it a couple of minutes to actually have an effect. It's not going to be instantaneous because you've got to get obviously through your IV, you've got to get into your system, you've got to get it circulating. So I'm going to pop that on. And hopefully what we will start to see is this will happen. Okay, and let's go a wee bit more. All right, so, yes?
What do you do if you don't have noradrenaline?
So if you don't have noradrenaline, I'm going to ask, what do you have?
I don't have either.
Yeah?
Could you use glycopyrrolate?
So I'll come back to glycopyrrolate in a minute, why we wouldn't use that in this situation. Cool. So if you don't have vasoconstrictors, that's fine. So the main vasoconstrictors that we have are noradrenaline is top one, ephedrine, and phenylephrine are the other one that tend to be used. If you don't have them, that's fine. Do you have anything like dobutamine or dopamine? Okay. Do you have anything, what am I trying to think? Do you have adrenaline? Okay. So adrenaline is not first line and isn't something you would be using this one. So I'm going to say don't crack it out, okay? Crack it out when it's an emergency, but try not to in this situation. So really what you are going to want to be doing in this one, if you have no emergency drugs that you have in your practice. So I'd be having the conversation about getting something. And noradrenaline is something you can use in quite a lot of patients. It's cheap and cheerful. The vials are single use. You can charge, like, they're actually really useful to have. And if you're going to be doing things like this, they are definitely worth having in your practice. Otherwise, dopamine or dobutamine, having one of them is good. So yes, they don't vasoconstrict, but they are positive inotropes, so they're going to improve contractility, and again, can be quite beneficial in these situations as well.
Sorry to interrupt.
Yeah.
Would you use one over the other for dopamine versus dobutamine?
Yes, so I have a personal preference, which is based on nothing other than I have a personal preference, which is dobutamine, my personal preference. If you have one or other, it doesn't matter. Depending on who you ask, depending on what studies you read, depending on what day of the week it is, people will have opinions about it and they will change their opinions on that. I'd rather that people have one of them and know how to use it and use it properly than have both of them, don't know what they do, never use them, and they go out of date in the back of their cupboard. If you don't have any form of vasoconstrictors that you can use, then what you're thinking is, can I max spare any more here to reduce my inhalant use as much as possible? So can I add in the fentanyl CRI? Can I add in, obviously I've got my ketamine CRI, I'm going to be increasing that, midazolam CRIs, and in all honesty, I quite like Tiva in these situations. So Tiva, using a propofol CRI, actually can have a more beneficial effect on your blood pressure. Oh. Later, go away. We do not need a system update right now. Would be quite good in this situation because it seems to be slightly better for your blood pressure than an inhalant is. That being said, if you have nothing, you're going to be thinking, well, I can improve, max out on everything else I can, and then I'm going to be, again, making sure my fluid situation is good, potentially thinking, right, I can't vasoconstrict. Do I need to think about a colloid at that point in time? Or is it teetering that I can manage without? Then you do have the big question of obviously then adding in something like, yes, your alpha-2 agonist is what we're going to be thinking about this because they do vasoconstrict your patients. Yes, they vasoconstrict, but do they vasoconstrict in an appropriate way? We don't know. Will it potentially negatively impact your outcome? It's a hard thing, and it's a hard question to answer, and I don't think it's a right one because they're going to have a negative impact on other parts of your cardiovascular system. You can always try and then antagonize. That is the big thing and the beautiful thing about alpha-2s, but I would be saying that's my absolute, like, I really have tried everything else, I'm really struggling, might help, but it would make me feel quite uncomfortable about it. My biggest thing would be have the conversation in your practice. These drugs they're very, very generic. They're not expensive drugs, and actually you'll find you're probably using a lot more than you think you do. And you don't need to have all of them. Absolutely don't need to have all of them. You can have one of them, and so you can have something there that you can use. And I think that conversation is a great one to have, and is something I would definitely be leaning towards. Okay. Glycopyrrolate. Sorry, that was the other question. So glycopyrrolate is an antimuscarinic. Antimuscarinics are very good at increasing your heart rate in patients that do not already have an increased heart rate. So your patient, if are sitting at 120, in a large breed dog, that's quite high for a large breed dog. So I would not be leaning for anything like atropine or glycopyrrolate in this patient, because all it's going to do is increase my heart rate further. And while heart rate increases when you're bradycardic are really, really good, when you're tachycardic, what they're going to do is decrease your diastolic time. So the less time your heart has in diastole, the less time your heart has to fill. So what you're going to find is you're going to do this. If you gave glyco here, which is what we're going to have, probably going to do something like this. Yeah. So what you'll probably find is you'll probably get a really, really wonderful heart rate, but your blood pressure will probably tank out because you're not actually giving your heart enough time to fill. And you may even give yourself some wonderful arrhythmias in that one as well, which I could probably actually, let's see, what can we give you? Where is it? Might even give yourself something that looks a little bit like this. Yeah, hold on, let's go a bit higher. Yeah. Which we don't really want to do. We don't really want our patient in this situation. So this is supraventricular tachycardia. So what we want to do is, in these situations where we already have an increased heart rate, we're not worrying about the heart rate. The heart rate isn't the problem here. The heart rate is trying to manage the problem, which is I'm either vasodilated, I don't have enough volume, or I'm not contracting very well. And that's the problem that we need to treat. Cool. Right, let's get rid of that one. Let's go back to there. Sorry, let's get our patient back to here. Okay, so we've got to the end of the procedure. We haven't had to give him ventricular fluid. We popped our noradrenaline CRI on, and this is sort of where we've teetered around, and our patient's been quite happy and quite comfortable throughout. So surgeon's closed, and we're now going to start thinking about recovery. Hold on, let me do this. I forgot about that. What do we now need to start thinking about in this patient? Temperature, great. So we're a little bit hypothermic, not as bad as I've been quite kind here, not made you too hypothermic. So we know this patient's still a little bit cold. So what does that mean they're going to do in recovery? Shiver. Is shivering nice? No. So shivering is not a pleasant experience. It can also be quite painful if you've already got wounds. And what else does it do? Not necessarily reduce blood flow. Yeah, so that's the aim of it. We're kind of trying to increase our heat. But the biggest thing it does is actually increase your oxygen requirements. So you will get a massive increase in oxygen requirement when you start shivering. So this patient, we know, is potentially going to shiver in recovery. We need to make sure we have oxygen supplementation available for them. and to keep an eye on their oxygenation because they're going to have a big increase in their oxygen demand when they start shivering. Okay. Yeah.
Do you ever keep them under slightly longer to try and increase their temperature before waking, or would you always wake over the temperature?
Yeah, so in this situation, this isn't that low. I'm not too worried about that. But in very, very cold patients, yes, I absolutely have done. As long as they are cardiovascularly stable and keeping them under the anaesthetic isn't going to be more detrimental to them. So if I had a really sick patient who's very cold, who is not coping cardiovascularly, I'm going to be warming, waking up and doing the best I can to kind of balance that act there, because yes, we don't want them waking up freezing cold. That's not great for them. Freezing cold is also going to prolong their recovery, but prolonged anaesthetic is going to have a negative impact on their cardiovascular system and potentially on their outcome as well. So it's playing that balancing game as best as we can. Anything else we're going to start doing about this patient? Recess analgesia, yep, so we're going to make sure we have an analgesia plan. So we gave them methadone on pre-medication. It's been maybe about 2 hours since then, so hopefully that'll still be doing its thing. We've got our ketamine CRY on board, so hopefully we're going to be nice and comfortable. Anything else? Yeah, absolutely. So we're about to go to recovery. We are about to start waking this patient up. We need to make sure that 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 esophagus is free of fluid, because there will be fluid in there. If the surgeon has had to go in, has been manipulating the stomach, there's a high chance that we're going to have fluid going into the esophagus. So I'm going to want to suction the esophagus. If I am getting anything out, I am potentially going to think about flushing. Because I have given omeprazole to this patient, I am probably less concerned about administering anything like sodium bicarb, because the gastric contents will be less acidic, so we don't need to worry too much about that. What you can do is, if you've got any litmus paper, you can test it and actually see what it is and then base your management based on that. That would be what I would do. But dilution is the solution to pollution. So if you've got loads that are in there, absolutely get it flushed out. Okay. Otherwise, that's kind of what I'm going to be thinking. So I'm going to keep my monitoring on, because I know this patient is going to need to be monitored into the post-operative period. So I want to make sure I keep as much of it on as I can. Suction the esophagus, give it a flush if need be, make sure that I've got oxygen available for recovery, and get them into sternal recumbency to start that recovery procedure. So we have our patient. We have turned them into sternal. We've taken them off of the oxygen, we've turned them into sternal, and this happens. Oh, and apparently it starts talking as well. There we go. Okay, what's happened? Yeah, so our oxygen's dropped a little bit. Okay, am I worried at that point in time? So we've just taken us off of oxygen, we've turned into sternal. Okay, so I'm not worried, but I'm thinking. I'm like, there's something going on here. My patient has dropped their SpO2 when I've taken their oxygen off. So this could be a couple of things. So, well, actually, what could be happening here? Yeah? Yep. So what is the beautiful thing that I've still got down the bottom that's telling me that I don't have a tube blockage? Yeah, CO2. So my CO2, my capnograph is still looking normal. Absolutely, definitely something I have to think about, but then I'm assessing that and going, right, I don't have a tube blockage here, great. Not worried from that point of view. What else are we going to think about? Yep, so my end tidal CO2 is 39, my respirate is 6. So yes, absolutely could be hypoventilating. So although that carbon dioxide is normal, we could actually find that if we took a blood sample and we checked our arterial carbon dioxide, it could be significantly higher, because we know this patient is at risk of a VQ, a ventilation perfusion mismatch. So actually this patient right now looks like they're not hypoventilating, but what we could find is absolutely they actually are. So yes, hypoventilation definitely could be a contributing factor to this. What else? What could this patient have done pre-coming in to see us? Yeah, so they could have aspirated, and they could have aspirated pre-G. We haven't done any chest x-rays. They absolutely could have. So I've got that running through my head right now. So I'm going to stick them back on oxygen because I want to get that SpO2 up. And I'm going to make sure that I keep that in the back of my mind, that this patient has desaturated when I take them off of oxygen. So I'm going to start waking them up. Okay, and then that's going to come up. Let's drop this down a wee bit. So we're off of our inhalant, we're waking up quite nicely, still on oxygen at this point in time, but looks like our patient's recovering relatively well right now. So I'm now going to do a test off of oxygen before I have them completely awake again. So I'm going to take them off of the oxygen, and it does this. Okay. It's still dropped, but it's not dropped as much as it had beforehand. So I'm going to be saying, right, I'm happy to recover this patient right now. So I'm still thinking hypoventilation has probably been a contributing factor to what we had going on. However, I'm not going to rule out at this point in time that this patient hasn't aspirated. So while we haven't had any regurgitation, we haven't obviously had any aspiration with us, it's not to say this patient hasn't done before it came here. So So what we'll do is, once this patient's awake, if they're not saturating normally when they are fully awake and fully recovered, then I'll be thinking, right, I'm probably going to POCUS, or I'm going to do a chest x-ray to confirm or deny whether or not they've got anything going on in their chest here. Because just because it didn't happen with us doesn't mean it's something that couldn't have happened in this patient, because we've already identified that it was a possibility. Right, perfect. And that's us. I think we'll go for that one because that's been quite long. All right. Does anyone have any questions, or does anyone want to do anything else to our patient before we go away? Yeah. Oh, sorry, I mentioned it way earlier on. Sorry, completely forgot. Absolutely give paracetamol in this case. 10 to 15 mg per kg. I tend to go 15 mg per kg IV in patients where there is query about their perfusion of their liver and things like that. If I'm a little bit worried, I'll maybe drop it a little bit or not give it at all. But in this patient, absolutely paracetamol all the way. Yes?
I'm a bit worried about his heart rate considering how big the dog is.
Yeah, so I'm not worried. I'm aware that this patient is still tachycardic, but I can explain it all. This patient is not normal yet. We're going to have to continue to manage this patient. We're going to have to continue managing their blood pressure, their volume, status into the recovery period. But I'm not unhappy right now. This patient is at a stage where they are compensating well for what is going on, and I can explain everything that's going on here, and this will improve over time is the idea. So I'll continue to monitor. I'm going to continue to replace the fluid as need be. I'm not thinking I need to do loads about this right now. I'm thinking we're going to monitor this and see how we get on. If anything changes, we'll readdress the situation. Yeah. Anything else? Yeah.
Do you like warm fluids or something? Because the temperature's still quite low.
Yeah, so warming fluids. So you can warm fluids. Yeah, for a fluid warmer if you've got them, but unless you've got one of the fluid warmers that's on the line near the patient, the effect of it's actually pretty minimal. What I would be saying is just don't have freezing cold fluids. So making sure that they're not straight out either out the fridge or, in our case, from the storeroom up the stairs that's absolutely Baltic. So yes, the effect of warming fluids in this patient, unless you've got the fluid warmer that attaches straight on, isn't going to be great. I'd be going for my warm air devices, so bear huggers and things like that. Lots of blankets, lots of insulation. That's what I'm going to be thinking about here. And as soon as they're up and moving, this is a temperature that's up and moving, they'll get themselves toasty. Yeah?
A question that's more specific to our practice, but we've been using forever and ever Humphrey only.
Yep.
So very recently we had to acquire a second machine, which is a standard. So now the Humphrey is only in theatre. So apart from pre-oxygenating the patient for a little bit extra time, anything more specific, because we're going to be inducing that patient on the standard machine?
No, so I'm presuming standard machine, you've still got circles, TPCs, depending on patient size. No, for me, it's absolutely the same. I think the last time I used a Humphrey AED was when I went to visit a practice once, and that feels like about 4 or 5 years ago now. The principle is the same. So if you're using a large breed dog, this is going to be a circle. It is going to function in the same manner, which is your oxygen is going to be very similar. So you're going to start at 2 to 3 litres. I tend to go for 2. You're going to drop it after 10 minutes down to half to 1 litre, depending on how comfortable you are with that. Your isoflurane, everything is the same in that there's nothing special that you have to do with them. TP, so obviously just make sure you're assessing their calculating their oxygen flow to make sure it's appropriate, or assessing it based on your capnography. No problem. Yes? No, I wouldn't be giving a non-steroidal to this patient. So this patient has every indication that they have got poor tissue perfusion. So they've been hypotensive. We've had to give them a lot of fluid. They've also just had surgery on their stomach. So for me, these are all indications that I would not be giving a non-steroidal to this patient. Non-steroidals are great and they have their place, but we worry about our kidneys with them. And anything where we have reduced perfusion to our kidneys, so things like hypovolemia, we then don't want to add to that by giving a non-steroidal. So non-steroidals are COX inhibitors, and actually your kidneys for normal renal perfusion really do rely on the COX enzyme. So that's actually how they make sure that their blood flow stays quite steady, despite what else is going on in your body. So if then you take that away and then you add in hypovolemia with that, your kidneys are at very, very high risk of becoming damaged. So this patient would not be getting a non-steroidal from me.
Even one subcut injection, would you still not able to do that?
No, absolutely not. Patients that are hypovolemic are really, really high risk from acute kidney injury associated with non-steroidal use. If this had been obviously a spay that had an episode of hypotension under anaesthetic, you probably would be absolutely fine. But in this specific patient, we have every indication that this patient, even without a non-steroidal, could actually go on to develop something like an acute kidney injury anyway. We've had hypovolemia, we've got a lot of inflammation going on, we're not exactly normal yet. I wouldn't be risking it in this patient.